Hello, wonderful staff of the Northwest Kidney Center. Today we're going to talk about fluid management in dialysis patients with the goal of answering the question that you all are asked every day, many times over by our patients: how much fluid are you going to remove today? Recall that dialysis has two main functions: removal of waste products and the removal of fluid. So today we're going to talk about fluid removal, which is an integral part of something known in the dialysis world as volume management or volume control, and I'll go into that in more detail later in this talk. I have three objectives for you. One, understand the importance of removing fluid in dialysis patients, recognize the clinical complications of fluid retention, and develop an approach for assessing dialysis patients for fluid retention. The impact of fluid overload on our patients is profound. Fluid retention is nearly universal in dialysis patients. Pretty much everyone in our dialysis units is retaining some fluid, and this can have significant negative clinical consequences. Excessive fluid retention can lead to elevated blood pressure in our patients. If you have too much salt and water inside of your blood vessels, this increases the pressure inside of the vessel, resulting in high blood pressure. High blood pressure in turn can cause many different types of heart problems. Volume overload is a source of stress on the heart. Recall that the function of the heart is to pump blood, and if a heart has to pump too much fluid, it gets stressed, and over time the muscle of the heart gets thicker, and we call this left ventricular hypertrophy. You can see a picture of a normal heart on the right, and just to the left of it is a thickened heart muscle. This is thought to be bad for the heart because it disturbs the normal flow of electricity through the heart, and is one of the reasons why dialysis patients have an increased chance of developing arrhythmias, or an abnormal heart rhythm, which can lead to sudden cardiac death, among other problems. If you have too much fluid inside of your blood vessels, you can also develop heart failure. Chronic fluid retention in the long run increases the risk of weakening the heart muscle. We call this heart failure. And in this situation, the decreased contractility or strength of the heartbeat can lead to low blood pressure, and this can make fluid removal on dialysis even more difficult. The development of heart failure is often associated with a significantly higher mortality. Excessive fluid in the body can also accumulate in the lungs, leading to what is called pulmonary edema, and this manifests as shortness of breath. You can see the x-ray here. The lungs should be black, but instead are white, and that represents fluid that has filled up the air sacs within the lung. Even mild pulmonary edema can lead to a significant increase in hospitalization, morbidity, and mortality. Fluid retention can also cause congestion of other organs as well, such as the liver, the intestines, and the legs. This can lead to all sorts of symptoms which we'll discuss, including nausea, abdominal pain, lower extremity discomfort, among other symptoms. So our main job with dialysis is to make sure that we remove enough fluid, and that involves an assessment of patients' volume status. So when a patient comes to the dialysis unit, the million-dollar question that he or she typically has is, how much fluid are we planning on removing that day? Of course, patients who have been on dialysis for a long time usually know how much fluid they want to remove, or are willing to remove, or can handle to have removed. But many times, particularly if the patient is new to dialysis, they turn to us to decide. As you all know, dry weight is one of the most useful tools we have in determining our fluid removal target. So what is dry weight? In its simplest definition, dry weight is the weight that the patient should ideally have if there is no excess fluid. It's chosen by the nephrologist and can fluctuate frequently. On a more technical level, dry weight is the body weight at the end of dialysis at which the patient can remain normotensive, so have a normal blood pressure until the next day without blood pressure medication. That is, it's the ideal post weight that allows for a normal blood pressure. But the main problem with dry weight is that its value is often incorrect. That is because it is not a static measure. It can fluctuate based on factors such as soft tissue weight gain or loss, what someone's wearing for the day, the effectiveness of dialysis treatment. And intuitively, this makes sense from our own experience, as our own weight often fluctuates by a pound or two on a daily basis. Plus, if a nephrologist either doesn't see the patient regularly or doesn't change the dry weight very often, over time the value can deviate more and more from what is true or correct. And that's why it's good to have other ways to assess patients for fluid retention or volume overload rather than rely exclusively on the dry weight. And there are several physical examination findings of fluid overload with which you should be familiar. Lower extremity edema is the most common finding of fluid retention. Because we live in a world with gravity, any extra fluid that's retained in the body tends to fall to our legs when we stand. So edema is most often in our feet and ankles. However, when a patient sits in a dialysis chair or lies in a bed, sometimes the extra fluid can redistribute into the calves and the posterior trunk or the thighs. While edema is a good marker for fluid retention, it's important to recognize that the absence of edema does not exclude the possibility of fluid retention. It's generally thought that edema does not occur in the legs until a patient is retaining at least 3 kilograms of fluid. Another common physical examination manifestation of fluid retention is something called jugular venous distension. So the jugular vein is located in the neck, and if you can see the neck vein, you can measure the vertical height of the column of blood above the right atrium. So the right atrium is located in the right upper chest, and if you measure the distance between that and the top of the column of the blood, you can estimate something called the central venous pressure, or CVP. Normal CVP is less than 9 centimeters of water, but it tends to be much higher in most dialysis patients at the start of their treatment. So if you've not been in the habit of looking at people's neck veins, recognize that this is an important and useful gauge for assessing fluid retention. There are several lung or pulmonary manifestations of fluid overload as well. The first one is crackles. Crackles represent a Velcro-like sound that typically occur during late inspiration. So you ask the patient to take in a deep breath, and towards the end of that breath you hear this snap, crackle, pop of the alveoli that are opening because they were previously closed, often because of the presence of fluid. Decreased breath sounds, particularly at the base, may represent fluid around the lungs, which we call a pleural effusion. And in the chest x-ray shown here to the left or to the right, you can see a left-sided pleural effusion, which would manifest on exam as reduced breath sounds or poor air movement. Finally, a lot of dialysis patients present with wheezing. Wheezing is an expiratory sound that often sounds high-pitched, and typically we associate with asthma or COPD, but it's commonly seen in patients with pulmonary edema, and that's why we call it so-called cardiac asthma. So what are the cardiac manifestations of fluid overload? Well, if you listen to their heart, you might hear an extra heart sound, or a so-called gallop. So normally you hear lub-dub, lub-dub, lub-dub. That's called an S1 and S2. If you hear a third sound like da-da-da, 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 that's what we call an S3 gallop. And it occurs just after the S2 when the mitral valve opens and allows passive filling of left ventricle, and it's typically produced by a large amount of blood striking a compliant left ventricle. So if you hear 3 heart sounds rather than 2, they probably have an S3 gallop. You might also hear a murmur. A murmur represents a disturbance to blood flow, most often secondary to a problem with one of the heart valves. Heart valves are doors through which blood flows from one chamber to the next, and sometimes the valves can become sclerotic or scarred and shrink in size, and we call this stenosis. So sometimes the valves stop working well and preventing blood from flowing in the wrong direction, and we call this regurgitation. So in both situations, people can develop a heart murmur. Finally, a patient may have a fast heart rate. We call this tachycardia. So it's very common to have a fast heart rate in the setting of heart failure or fluid retention because the heart is trying to increase its cardiac output by increasing the heart rate. So there's a formula that you don't really need to know, but it's cardiac output equals the stroke volume times the heart rate. Stroke volume is the amount of blood that is expelled during a single beat. And so the volume that is pumped out of the left ventricle with each contraction increases if the heart rate is faster. And so a fast heart rate is a common compensatory finding in the setting of volume overload. So those are the physical exam findings that you might see in a dialysis patient who has volume overload. What about the symptoms of volume overload? What might patients complain about when they come to you if they are fluid overloaded? Recall that volume overload leads to a congestion of organs, sort of like a wet sponge. And so most of the symptoms occur as a consequence of organ congestion. So for example, if the lungs are congested, if you have pulmonary edema, patients present with shortness of breath. If you have congestion of the liver, people often have abdominal pain, particularly on the right side. If their intestines are congested, they often feel bloated, have nausea, and reduced appetite. And of course, if you have congestion of the soft tissue in your legs, you will present with edema. Patients also usually have shortness of breath, and there are different manifestations of that. Someone might have something called paroxysmal nocturnal dyspnea. Paroxysmal means a fit or attack that comes and goes. Nocturnal, of course, means at night, and dyspnea means shortness of breath. So basically, it's a fit of shortness of breath that occurs typically at night when a patient lies down in bed. And oftentimes it awakens them from sleep and is usually relieved in the upright position. Sometimes patients go and open the window, breathe in some cold air, take deep breaths, and then they feel better. Another type of shortness of breath that people can have is called orthopnea. Ortho is a Greek word for straight, and pnea means to breathe, so refers to breathing when you are in the straight position, i.e. flat. So it's shortness of breath that occurs when lying down, usually flat in bed. And in general, patients breathe more comfortably when they are reclined at an angle or sitting upright. And this is because we live in a world with gravity. When we sit or stand up, gravity takes fluid out of our chest and distributes in the lower half of our body. But when we lie down, fluid can then migrate from the legs back into the chest and go into the lungs, causing shortness of breath. And finally, patients often present with dyspnea on exertion. Dys is the Greek word for difficult, pnea or breathing. So dyspnea on exertion is difficulty breathing with usual activity. Most patients who are retaining fluid, dialysis patients or patients with congestive heart failure, report dyspnea on exertion. And you can just tell by watching the patient walk across the room to the dialysis chair if they are having difficulty breathing. And if they are, that should be a clue to you that you should take off more fluid with dialysis. And finally, patients often complain of a frequent cough, particularly at night when they have fluid retention in their lungs. So a nocturnal cough is exactly what it sounds like. It's a cough that occurs at night, most often when the patients lie down in bed, although it can occur also during the day, even when they're sitting up if they have pulmonary edema. Fluid distributes from the lower half of the body back into the lungs when a patient lies down in bed at night, and that causes pulmonary congestion. And that triggers patients to cough. The lungs are trying to cough out the extra fluid that's in the airways. So it's a very common manifestation of fluid in the lungs. Aside from dry weight, physical exam findings, and symptoms of volume overload, we do have some other tools to assess fluid status. Examples of other tools to assess volume status include bioimpedance spectroscopy, lung ultrasound, and crit lines. Again, we don't use these technologies at the Northwest Kidney Center, but some dialysis units use them around the country. Bioimpedance spectroscopy is basically defined as the ability of biological tissue to impede or obstruct electrical current. The idea is that fat, muscle, and fluid differ in their electrical impedance. So each tissue type lets electricity flow through it in different ways. So the idea behind bioimpedance spectroscopy is to send a tiny, safe electrical signal through your body and see how quickly the signal moves. And that can give you different estimates on body composition, specifically with respect to fluid content. Another way to assess volume status is to look at the lungs using ultrasound. So ultrasound uses sound waves and passes it through the tissue. If there's only air in the lungs, then the sound waves pass very easily and don't reflect back to the transducer, and they look black. On the other hand, if there's fluid in the tissues, the lungs appear to be white, and they refract some of the tissue back to the transducer. Crit lines are another device that attaches to a dialysis machine to monitor hematocrit and the percent change in blood volume and oxygen saturations over the course of the treatment. And based on the data that the monitor provides, you can adjust the ultrafiltration rate over the course of the treatment. For example, if the line is flat, as in profile A, basically indicates that the patient's plasma refill rate matches that of the ultrafiltration rate. And so basically allows you could probably increase the ultrafiltration rate without causing symptoms. On the other hand, there's a gradual slope of the line in this case, meaning that we're actually removing fluid at a rate faster than the plasma refill rate is. And then in the third diagram, or C profile, basically this is a steep slope indicating a rapid decrease in blood volume. So there's a higher risk of interdialytic symptoms or hypotension. So in this case, you'd want to back off on the ultrafiltration rate. Speaking of ultrafiltration rate, this is one of the most critical aspects of volume management in the dialysis population. So it refers to the rate at which fluid is removed over the course of the treatment. Specifically, it's defined as the volume of fluid divided by the duration of dialysis, and that's standardized per the weight of the patient. So for example, if we remove 2 liters over 4 hours, we're removing 500 mils per hour. And if you divide that by the weight of the patient, that's going to be 7 mils per kilogram per hour. It's important not to remove fluid at too fast of a rate, because recall that we are only removing fluid initially from the plasma volume, so the fluid that's inside of the blood vessel space. And then over time, we hope that fluid from inside the cells, which is the intracellular fluid volume, and in between cells, which is the interstitial space, goes in to replace what has been removed. So you obviously can't remove, 3 liters an hour, because that would remove, all the fluid in the plasma space at a rate that is much faster than it could be replaced, and that would result in hypotension and cardiovascular collapse. Many studies have demonstrated that a high ultrafiltration rate is associated with increased mortality. So in this study, for example, there were 182 patients on dialysis for at least 6 months, and they looked at the mean ultrafiltration rate for each patient over 1 month, and they looked at all-cause mortality, and they found that patients who had an ultrafiltration rate of greater than 11.7 mils per hour per kilogram had much lower survival than those who had an ultrafiltration rate of less than that. That's one of the reasons why we like to dialyze people for at least 4 hours. If you have a shortened dialysis duration, say of 3 hours or even less, you have to remove the same amount of fluid in a faster period of time, resulting in a greater ultrafiltration rate, which again is associated with greater mortality. And a significant chunk of dialysis patients in the country dialyze for less than 3 hours. It's about 1/3 of all dialysis patients in the United States dialyze for less than 3 hours. And at the Northeast Kidney Center, we don't think that's good for patients. Of course, the discussion on volume management in dialysis patients wouldn't be complete if I didn't emphasize that removing fluid with dialysis is not the only way to control fluid. It's very important to limit the amount of sodium intake. So for example, the retention of sodium drives thirst, which leads to more water consumption and therefore more retention. Then of course, when appropriate, consider diuretics, which help control fluid overload in dialysis patients by promoting urine production in the interdialytic interval. Additionally, you have to be careful with antihypertensive medications because if you give too many antihypertensive medications, they can develop intradialytic hypotension, which can limit fluid removal during dialysis. All right, now let's summarize what we've learned today. Volume management is incredibly important in dialysis patients, and their chronic retention of fluid can have significant adverse clinical consequences for our patients, including hypertension, thickening of the heart muscle or left ventricular hypertrophy, heart failure, lung problems, lower extremity edema. Dry weight is the body weight at the end of dialysis at which a patient can maintain a normal blood pressure until the next day without antihypertensive medication use. It's a very useful tool in letting us know how much fluid to take off, but there are limitations due to its inaccuracy and the fluctuations that normally occur with body weight. Signs of volume overload include lower extremity swelling, distension of the jugular vein in the neck, crackles or decreased breath sounds on lung exam, wheezing, an extra heart sound called an S3 gallop, a heart murmur, or just a fast heart rate or tachycardia. Symptoms of volume overload include shortness of breath with minimal activity or usual activity, something called paroxysmal nocturnal dyspnea, which is shortness of breath that awakens someone from from asleep at night, orthopnea, shortness of breath when someone lies flat, and a nocturnal cough. Other techniques to assess volume status, which we don't currently employ at the Northwest Kidney Center, include bioimpedance spectroscopy, lung ultrasound, and crit lines. The ultrafiltration rate is very important not to remove fluid too fast. That's an argument in favor of longer or 4-hour dialysis sessions. And finally, dietary interventions are very important, so encourage all of our patients to avoid salt, and diuretics may be helpful in promoting fluid management in between dialysis treatments. All right, brace yourself for the monthly quiz. Question number 1, why is chronic volume overload bad for our patients? That's right, so it can cause elevated blood pressure or hypertension, thickening the heart muscle, left ventricular hypertrophy, heart failure, and increased mortality. Question number 2, how much fluid do you need to retain before you typically develop lower extremity edema? That's right, so 3 liters. So if you sense that a patient on physical exam has edema in their legs, they probably have at least 3 liters of extracellular fluid in their body. Question number 3, name 3 physical examination findings of volume overload. That's right. Distension of the jugular vein in the neck, so jugular venous distension, crackles when patient takes a deep breath in, decreased breath sounds suggestive of fluid around the lung or a pleural effusion, and finally, lower extremity edema. Question number 4, name 3 symptoms of volume overload. That's right. So shortness of breath with usual activity, or so-called dyspnea on exertion, paroxysmal nocturnal dyspnea, or these attacks or spasms of shortness of breath that typically occur at night when someone is asleep, orthopnea, shortness of breath that occurs when someone is straight, particularly when they lie flat in bed at night, nausea if they have intestinal congestion, reduced appetite, same reason. Final question, name 2 tools to assess volume overload. Correct. So bioimpedance, lung ultrasound, and crit lines. This concludes the January 2025 in-service for the Northwest Kidney Center. Thank you for everything you do for the organization and for our patients. This is Andy Brokenbrough signing out until next month.